Thanks, Roger. Shockingly, we have 4 people from San Diego here, I think. 3 or 4 people at least from San Diego. I don't know why people decided to come to New York in December. More involved, bringing the weather with us, more involved, but I'm just going to tell you, this talk is going to be the most important thing that you guys hear in the next 2.5 days. There's nothing more important than that. And Louise is laughing at me, but his picture here is right here as I'm standing with him. And at the end of this talk, you're going to say that shockingly, Louise has done it again. And I'm talking about single position surgery only because that's how it kind of got started in this new technique. What I'm really going to be talking about is Prone Transpsoas. So lateral surgery, lateral interbody fusions in the prone position. And Louise and I have been doing that for quite some time now, and it evolves from single position surgery because single position surgery in the lateral position was designed so we didn't have to flip the patient back and forth. And what we've done now is we have developed a new technique to do lateral in the prone position so you no longer have to flip the patient. Positioning is much easier, and you can work simultaneously, posteriorly, and in the lateral position. And you're going to also see from the early data we have that you're going to increase lordosis in that. So the one picture there is us sitting while we're doing the lateral surgery, and that's Louise and I standing there after one of the first cases. Lateral interbody fusion has a long history now, and the fact is that it started and has continued to advance. There's lots of good reasons why we do lateral interbody surgery. Excellent fusion rates, lower complication rates, less blood loss, short hospital stay. Every reason that we do minimally invasive surgery is embodied by lateral surgery. Natural tissue planes. So I'm not trying to convince you that you should do lateral surgery, although it's great for deformity, and you'll hear from Dr. Mundis in a little while about anterior column releases and other things. But the overwhelming fact remains only about 20% of us are doing lateral surgery. So we have a long history. We've got an excellent literature. We have techniques and well-published, but only 20% of spine surgeons are doing lateral surgery. And why is that? Questions about neural complications. People don't want to rely on indirect decompression. They don't want to flip the patient back and forth. They're not willing to do new techniques. And the problem with flipping the patient back and forth is that it has forced us to do things that we wouldn't normally do. So the question I always get asked when someone's in the lateral position is, well, do you put on a lateral plate? Do you do a standalone? Do you flip the patient over and put in pedicle screws? And we've made that decision-making process much, much more difficult than it needs to be. And that's a problem because we know that posterior pedicle screw instrumentation is the gold standard for fixation, and it prevents subsidence, it prevents loss of correction, it enhances your deformity correction, and you have better results with it. So single position surgery became the idea that we'll put the patient in lateral and then we'll put pedicle screws in the lateral. I was talking this morning to someone and I said the basic tenet of this surgery is that it's much easier to do a lateral surgery in the prone position than it is to put pedicle screws in a lateral position. If you look at the literature, about a 5% breach rate, 3% misplaced symptomatic pedicle screws. They're not recommended more than 2 levels. You really can't get as good a correction as you can in the prone position, and you really shouldn't use it for more complex procedures. Single position surgery is well accepted in the literature, but very difficult to do from that setting. So what did we start doing? We started doing lateral in the prone position. You can see us standing there doing that. Why? Avoids a flip. Use easily to position the patient. You get increased lordosis from the prone position. You'll see a couple stats in the end are increasing lordosis, which we get from just turning the patient prone. All the guys doing posterior big deformities have a big advantage over lateral deformity correction because you put the patient prone and it makes a huge difference. You can work simultaneously. I'll show a couple cases at the end, and basically what you're able to do is pedicle screw instrumentation, laminectomies, releases posteriorly at the same time you're doing your anterior interbody fusion, which gives you large cage, good distraction, good fusion rates, all the reasons why we do lateral surgery. The real reason that some people don't do lateral surgery is neural injuries. Although this is not about neuromonitoring, I can tell you that When you're prone, it appears clearly based on our MRI studies that the lumbar plexus and the psoas muscle moves posteriorly with extension of the hips. And in fact, we improve the position of the psoas muscle when we place the patient prone to be able to do a lateral position, which alleviates some of our concerns at L4-5. You must be doing triggered EMG for the approach for the lateral surgery. I just keep reiterating that every time. I still go to meetings and I hear people say, well, I don't really need, I directly look and I do other things, but you should do triggered EMG. But the piece that most people are missing is that once you have your retractor deployed and you're compressing the nerve root and you have a safe working corridor, you need to have another neuromonitoring to identify the health of the femoral nerve during that time. And what that is saphenous SSEPs. Saphenous nerve is the terminal branch of the femoral nerve. It's the only sensory nerve. You absolutely can very, very well do SSEPs of the saphenous nerve, which gives you direct correlation to the health of the femoral nerve during the procedure and during compression. There's an excellent automated device out now called SafeOp that gives you not only nerve integrity, but identification and dilation. So you get both triggered EMG and automated saphenous SSEPs while you're doing the procedure. How do we do prone surgery? It's really pretty simple. You can either sit or stand when you do it. We position the patient in the usual prone position with a standard OSI table. And then if you want to sit down, we rotate the bed after we operate just a little bit, about 15 to 20 degrees, or you can stand. Dr. Pimenta likes to stand, and I like to sit during the surgery. And maybe it's because I haven't run as many marathons as he has. I'm not in quite as good a shape. Case experience, we absolutely have a good case experience already. Done over 100 cases with the group combined. These are the first 20. We wanted to do the first 25 cases. The fact is that we have really about 20 minutes from intubation and positioning to surgery. So once the patient's ready to go, it's much, much quicker, about half the time. No flip, no repositioning time, and we get simultaneous posterior decompression. No real complications. One small hematoma seen only by CT. A little bit of upper leg pain as expected. We had one person with some ipsilateral leg weakness, which recovered pretty quickly afterwards. But really what you get is alignment. You get increased lordosis. The fact is that if you're doing it in the lateral position, you get less than half of your cage to global lordosis, and you really have difficulty doing releases. So what happens now is that with a 10-degree cage, we're getting about 7 degrees for each cage. That's without any release or anything done posteriorly. So in fact, you don't need anymore a 20 or 30-degree cage to get a huge correction. You can now easily do a posterior release at the same time. And you can achieve much more than that. This is the first 20 cases, and we've gotten a lot better at positioning. So you really increased lumbar lordosis with a similar thing. The one other reason is navigation. So it's very easy to put an array on the spinous process when the patient's prone, and you can do your whole lateral and your whole posterior procedure with navigation, and then robotics is certainly going to follow. So navigation becomes much easier both for doing the lateral and the posterior aspect. And you just put it on the spinous process. Someone with locked facets, you're not going to get indirect decompression. So we have to go back and do a direct decompression in that spot, which makes it really easy in the lateral approach when the patient's prone to reduce their facets. And that's with facet disease. A long segment scoliosis, just adult degenerative scoliosis, 4-level scoliosis. Excellent correction at each level, nice lordosis, 10-degree cages, and we're getting for each cage almost 10 degrees in this position. So you're really getting what you put into it for global lordosis, not just segmental. Facet releases, this is a case that we had where someone clearly put the screws into the disc space and through the nerve root above. You have to take those screws out. The person really has a flat back. We need a good correction at the top. So now we've changed this into a surgery where we can take the person while they're prone, take out the pedicle screws, do our interbody work, do a distraction, release the facets in the back, and we got about a 22-degree correction for that, and that's really what's nice. L5S1 becomes easier, TLIF at 5-1 in the prone position, and in the prone position, lateral at 4-5, which I think is excellent. So what do we like about Prone Transpsoas? Number one, simultaneous procedures. You can do anything you want in the front and the back. SOAS appears to move posteriorly for the people that are concerned about neuromonitoring, but I couldn't stress enough, use saphenous SSEPs for nerve and health and triggered EMG for approach. And it allows for easier decision-making. All of a sudden, we don't have to decide, do I do a standalone? Do I put a lateral plate on? Do I take out the instrumentation posteriorly? We've just allowed everyone to do that. Navigation and robotics, I think, are going to become much easier in that situation. So I went over a little bit on time, and I think you can see why I think this is the most important thing that we're going to talk about all day long today. Maybe Dr. Hartle won't agree with me. Thank you.